Now, coming towards the platelets in the blood CP, if the platelet is low or high. If it is high, then the upper limit is 10 lakh. If there is more than 4,50,000 or 4 lakh to 10 lakh, this is reactive. Reactive means there is inflammation or infection. Inflammation or infection. The patient is having rheumatoid arthritis. The patient is having SLE. The patient is having worms infestation. You can expect the reactive increase in platelets. But if it is more than 10 lakh, think about myeloproliferative disorder. More than 10 lakh, think about myeloproliferative disorders. Now, if the platelet count is low, what is the best next step? Is it true thrombocytopenia or pseudo thrombocytopenia? The pseudo thrombocytopenia means sometimes the platelet become sticky and they adhere with one another. So what the machine do, the machine in which you do blood CP, they take this as a WBC. So the machine can give you a high WBC and a low platelet. Suspect pseudo thrombocytopenia in all those cases in which the WBC is raised and the platelet is low. The machine that is used for the blood CP, what it does, it cannot differentiate between the platelet and the blood CP. So between the platelet and WBC. So it gives the clumped platelet as WBC. So how can you differentiate between the two? If there is a thrombocytopenia, you must go for peripheral smear. The peripheral smear can tell you whether it is true or pseudo thrombocytopenia. If there is clumping, pseudo. If there is no clumping, true. What is the best next step if there is true thrombocytopenia? Whether there is decreased production of platelet or increased destruction of platelet. How can you differentiate between the two? You go for IPF. You go for IPF, that is immature platelet fraction, that is given in the blood CP. Most of the machines do not have this facility, but if you request them, they can do it for you. The IPF, that is the immature platelet fraction, that is just like a retic count of the RBC. A retic count of RBC. If the retic count is high, it means RBC production is normal. If the immature platelet fraction is normal, or high, that means production is normal. But if it is low, it means the production is abnormal. So what will you do if there is increased destruction, if there is decreased production? Now, if there is decreased production, what will you do? Go for bone marrow. What is the problem over there? Go for bone marrow. What is the problem over there? But if there is increased destruction, you can think of ITP. You can think of splenomegaly. You can think of hypersplenism. You can think of PNH, paroxysmal nocturnal hemoglobinuria. But in that, there may be pancytopenia. But they can give you true thrombocytopenia. So if the IPF is high, it means production is normal. No need of doing bone marrow as far as thrombocytopenia is concerned. But if the IPF is low, production is decreased, and go for bone marrow to exclude other organic causes. And if all the causes are excluded, bone marrow is normal. What is the cause? ITP. In most of the cases, it is the ITP. So in ITP, what will be the problem? That is, destruction is the problem. The antibody mediated destruction of the platelet is the problem. So in ITP, IPF will be high. So if you suspect ITP, you go for simple investigation, that is IPF, immature platelet fraction. If that is high, it means production is normal. So there is a high suspicion of ITP. If the IPF is low, it means the production from the bone marrow is abnormal. So the ITP, you can easily exclude the ITP by looking at the IPF.